It started with this man, biochemist W.C. Rose, who developed the first elemental diet for humans in the 1940s. After experimenting with animals, Rose fed his graduate students at the University of Illinois a solution of cornstarch, sucrose, butterfat, corn oil, inorganic salts, and a mixture of purified amino acids. He added a liver extract to supply vitamins and yet undiscovered nutrients, plus some peppermint oil for flavor. Then he demonstrated that his volunteers could be maintained in a positive nitrogen balance for weeks without complications. A few years later, Crohn's disease was described by this man, Dr. Burl B. Crohn. In the earliest reports of nutritional therapy, a liquid diet evolved from Rose's formulation resolved malnutrition in patients with Crohn's disease. In the process, the diets had a direct effect on successfully filling nutritional gaps resulting from the disease. This was finally well documented in the 1970s, with 13 patients using dietary management of an elemental formula 17 times over 22 days. All but one not only demonstrated weight gain, but improvement in biomarkers. In 1990, a 10-year retrospective study confirmed elemental diet effective in the dietary management of 96 of 113 cases of Crohn's disease. That's 85%, regardless of age, sex, location, disease severity, or associated complications. Yet the same study indicates that the elemental diet did not significantly induce long-term improvements. Relapse appears somewhat inevitable when patients return to a normal diet or do not proceed with a maintenance intervention. A 2016 review put the relapse rate at 50% within 6 months when patients return to a normal diet. But don't despair, the plot thickens. When the research broadens to include an elemental diet followed by a personal food exclusion diet or continuation of some degree of an elemental diet, it becomes an effective long-term strategy in the dietary management of patients with Crohn's disease. Returning to a normal diet just isn't in the cards to successfully implement ongoing dietary management. In maintenance studies for Crohn's disease, which look beyond short-term use of the elemental diet to ongoing use for a part of caloric intake, we see reductions of postoperative recurrence and the elemental diet being celebrated as a promising dietary management approach. Taken as a whole, the elemental diet research through the present day has demonstrated its favorable impact on altering the body composition, leading to weight gain, and restoring nutritional status. Let's now turn to the subject of how the nutritional implications of the elemental diet are understood in the context of the pathophysiology of IB, where host genetic factors set the stage of susceptibility with 164 associated gene loci. A second factor represents environmental influence, including smoking, geography, stress, psychological elements. Added to this, various antigens, including medications, and finally, the significant antigenic role of dietary components. The third factor, the microbiota, is currently the key focus of the pathogenesis discussion. In health, the microbiota of 100 trillion organisms constitutes a stable ecology until genetic predisposition combined with multifactorial environmental triggers destabilize this ecology to provoke the fourth factor, an immune system reaction, involving a breakdown of innate immunity and overreaction of adaptive immunity that leads to inflammation, ulceration, fibrosis, and ultimately nutritional losses. One large study observed undernutrition in 68% of IB patients. Why so much nutritional loss? This can be explained by, at the bottom end, excessive diarrhea, blood, and mucus. At the top, reduced food consumption due to poor appetite, nausea, vomiting. At the mucosal level, dangerous protein-losing enteropathy, which along with other losses increases nutritional requirements. Malabsorption results from inflamed mucosal surfaces or from developing SIBO. Absorption is further decreased due to removal of absorptive surface area with fistulas, strictures, and in patients with resections. Decreased GI secretions that liberate nutrients from food add to the absorption problem. And IB medications that affect nutritional parameters are the icing on the cake. The bottom line is, enough nutrient loss leads to protein energy malnutrition that alters body composition and sets up damaging micronutrient deficiencies associated with systemic complications. This makes protein energy malnutrition one of the most important factors linked to poor outcomes. That's why it's so important to elevate nutritional status, making it a key clinical objective. Ordinary nutritional supplements are usually inadequate to replete acute IB patients. They may be poorly tolerated, undigested, or remain unabsorbed. An elemental diet's unique formulation of monomers make it ideal for nutrient repletion. This alone goes a long way in answering the question, why an elemental diet for the dietary management of patients with inflammatory bowel? But it doesn't explain fully how an elemental diet can lead to decreased inflammation, which begs the question, by what mechanism does the diet act? The answer is complex, and it's best to back into the question by itemizing the elemental actions of the diet observed in the various studies. Proximal absorption leads to early assimilation of bioavailable ingredients. Improved nutrient status is demonstrated. Decreased mesenteric adipose tissue in Crohn's disease. Bowel rest. Decreased luminal exposure to antigens. Alteration of the microbiome. Reduced malabsorption. Decreased gastric, pancreatic, and biliary secretions that contribute to intestinal permeability and bacterial translocation across membranes. And overall, a modified immune response and degrees of mucosal repair. These actions of the diet have been observed, and yet it has not been possible to isolate how the consumption of the diet, the starting point, leads to the end result, mucosal healing, when observed. We can try to connect the actions, and it might look like this. But these efforts are defied by various studies. For example, it was once thought that nutrient status explained anti-inflammatory effects, but a study showed decreased inflammation occurred before improved nutritional markers were measurable. When decreased polymers were thought to be the key, studies showed that a polymeric diet was as effective as the elemental diet. Reviews of elemental studies have failed to confirm a cohesive chain of causes and effects. But better than trying to isolate a single mechanism, we can point to a confluence of parts, like interlacing gears in a complex system that together impact the complex pathogenesis of IB. That, at least, is how I visualize the diet's potential actions as a management tool, one that has been staring us in the face since William C. Rose fed the first elemental concoction to his graduate students, and Crohn's patients showed signs of mucosal healing from liquid enteral feeds. It makes you think of what Sherlock Holmes always said to his apprentice Watson when something finally became clear. After having been overlooked, he would say it was elementary, or should we say elemental? To conclude our discussion in the spirit of the word we began with, I want to answer the question, why an elemental diet for dietary management of patients with IB, in the most elementary and elemental, meaning basic and fundamental way. The diet is easy to implement and dispense, with more palatable products emerging for increasing patient compliance. It is well tolerated and is evidence-based, with significant research supporting its use exclusively or as a partial or half-elemental diet. Given the less than ideal efficacy of conventional care for an inflammatory bowel, the diet's use can be complementary, supportive, and flexible. The elemental diet's ability to increase nutritional status renders it useful to influence outcomes. And as we discussed, it couples well with whole food diets. Finally, the proposed mechanisms of action of the elemental diet makes its application a reasonable and rational approach to dietary management of inflammatory bowel and a useful tool for integrative physicians.